Okay, so we're gonna go over a few questions. I will start with a question for Dr. Blair. Is there any utility in monitoring EBV PCR in transplant recipients? If so, which is more clinically relevant, the whole blood or plasma PCR?
Yeah, this is a great question. You can imagine that I, with a half an hour, could talk a lot about different viral infections. I do think that there could be utility, and at my previous center, there were protocols in certain high-risk patients for EBV reactivation that there were PCR monitoring. In general, I personally like plasma. I think it doesn't matter as much as long as you kind of use the same assay every time you measure so that you're actually comparing the results across the board as opposed to getting serum versus plasma and trying to compare that.
Yeah, can I add something?
Yes, please.
Yeah, and I would add that we have clear guidelines to monitor our transplant recipient for EBV, especially in high-risk recipient, where we will be monitoring every 2 weeks for the first 6 months with the EBV viral load, and then we can go to monthly monitoring for the next 6 months. And whenever there's a positive viral load or detected viral load on 2 subsequent monitoring tests, then we will assess those patients for PTLD using a PET scan. So there will be an indication for a PET CT. For the intermediate risk, meaning that they're donor negative, recipient positive for EBV, they will be this monitoring, but less often, monthly for the first 6 months, and then quarterly for the subsequent 6 months. And for the low risk, they will be assessed early after transplant once or twice monthly, and then we will redo it at 1 year. And obviously, if there's a detected viral load, then we'll go with the same process and get a PET CT as indicated.
Great. So, Rania, I have a question for you. How do you do cardiovascular evaluation for patient on the waiting list? The question, how often and which test you use?
So we obviously start with the medical history and the physical exam with the EKG when the patient presents to the evaluation clinic. The first non-invasive test is an echo, obviously, and then we also, in intermediate to high-risk patient, we will order them for a stress test, and usually it's the PET cardio that we are getting in our patients, and based on the result, obviously this patient will be seen by and evaluated by the cardiology colleagues and discuss if there is an indication to go to a further more invasive testing like an angiography.
And along this line, for relatively high-risk patients, there any discussion about delaying angiography until they are closer to transplant and near the top of the list? So how you deal with those patients who are pre-dialysis, high risk, need angiography?
Yeah, we've been in this situation a couple of times where the patient, because they are not on dialysis and they would like to avoid contrast. So this is a very close conversation that we have with our colleague cardiologist, whether the indication is urgent. Obviously, indication, it's not something that we can avoid if like the it's a high risk patient and they're at high risk for acute cardiac events. So if we need to move forward with the angio, we do it. If it's like kind of could be deferred in terms of screening, then we will be optimizing their cardiology management and medication with the cardiology team, monitoring closely with repeated imaging and testing, like echo every 6 months, and we can push when it's possible, when it's safe for the patient.
Okay, and I think there's a question for Martina. Do donors developing ESRD receive a preference on the waiting list? you want to answer that?
Yes, the answer is quite simple. Yes, they do have priority on the waiting list if they end up with an end-stage kidney disease after donated a kidney.
And within the last year, we transplanted 2 patients within very few weeks of listing, who were donors before. Okay, so I think that's it. Thank you, and then we'll take a few minutes break, and we'll be back for the last session. Thank you, Dr. Blair. Thank you, Rania.